Welcome to today's symposium on vision-threatening neuro-ophthalmic conditions and the strategy for early diagnosis and management. Though it's named a stitch in time saves nine, the theme is basically tackling the vision-threatening neuro-ophthalmic conditions. As you all know, that the central nervous system is the only tissue in the body that does not regenerate, and the optic nerve, being an extension of that CNS, does not regenerate once damaged. This highlights the importance of an early diagnosis and prompt intervention to preserve vision. So today's symposium is focused on that, and without much delay, I'm going to invite Dr. Carmen Chan. She's going to give a talk first. It's not in the given order, because she has to present in a parallel session in another hall. So I invite Dr. Carmen Chan to give a talk on monitoring of visual functions in patients on ethambutol and hydroxychloroquine. So before she starts, Dr. Chan is a very accomplished uvea and neuro-ophthalmology specialist at the Hong Kong Eye Hospital. So over to you, Dr. Chan.
Thank you, Dr. Bassi, for the kind introduction, and I'm very glad to be invited here to speak in this instruction course. So my talk is on ethambutol and hydroxychloroquine toxicity, so no financial interest, of course. So I'm going to start off with a case with a 70-year-old male Chinese patient who was diagnosed with extrapulmonary TB in the abdomen, and he was treated with rifampicin, isoniazid, and ethambutol back in 2019. So typical a medical history of a 70-year-old man with ischemic heart disease, obstructive sleep apnea. Fortunately, his renal functions are normal. His normal visual acuity is near normal. So 9 months after starting on TB treatment, he presents with painless blurring of vision in both eyes for 2 to 3 weeks. So the visual acuity in both eyes went down to 618 with decrease in color vision. And this is what his Humphrey visual field looked like. So you can see that there's almost a bitemporal field defect here. So the OCT RNFL is completely normal, and so was the MRI brain orbit with contrast. The blood tests were non-contributory. I'm not sure why we did a pattern ERG, but perhaps because we weren't sure. We were investigating him as a visual loss of unknown cause, and it was consistent with both eyes optic atrophy. Both has optic neuropathy. So in the absence of an alternative course, and also with him being on ethambutol, we decided just to observe him without, by stopping the ethambutol. So we're very glad that he had some subsequent spontaneous visual improvement in the next 6 months. And in the next 6 months, his vision went back to the pre-morbid level with full color vision, and also his visual field defect resolved as well. So ethambutol optic neuropathy, well, I'm sure in India you know better than I do that it is commonly used to treat TB. The incidence of ethambutol optic neuropathy is at 1 to 2%. So other than stopping ethambutol, there's no effective treatment, and is only partially reversible. So early detection is very important. So the risk factors are dose-related, and the comorbidities which could increase your risk include low body weight, hypertension, renal failure, concomitant use of isoniazid, vitamin E, and B12 deficiency. And of course, older age group patients are also more at risk. I think we've previously prepared this in a handout anyway, but I'm not sure where that is available. So
no, it's been uploaded.
It's been uploaded. So all the details and the references are there. So it's of insidious onset. It can happen anytime from 1 month to 36 months, with a median of about 8 months. So our patient, 9 months is just about the right time. So, and over 60% with painless, bilateral, symmetrical visual loss. They have dyschromatopsia and also visual field defect. And the bitemporal hemianopia is actually quite characteristic in ethambutol optic neuropathy. So there's no standard monitoring protocols and guidelines. If I ever have a chance to learn more about this from you guys, I would like to know what you guys do in India as well. So for us in Hong Kong, the basic eye exam as a minimum, we have a visual acuity and color vision, and this is actually in Hong Kong is not done by ophthalmologists. It's done by the chest clinic, who prescribe the TB treatment, and then the patients are instructed to self-observe for visual symptoms. And also in Hong Kong, because TB treatment is directly observed therapy, so they have to go every day for the treatment anyway. So in fact, they are in touch with healthcare professional on a daily basis. So if they have any problems, then they can actually tell, they can seek help quite easily. So if there are visual symptoms, then the ethambutol must be stopped. And in cases where they have delayed or slow persistent visual loss, then isoniazid may also be stopped. Okay, for high-risk patients, they require closer monitoring. So moving on to a second case, a 62-year-old female Chinese patient with a systemic lupus erythematosus on prednisolone, mycophenolate, and also hydroxychloroquine, initially on 400 milligrams daily. So as with a lot of Chinese ladies, they are quite light, so she's only 50 kilograms. So that actually works out to quite a high dose of hydroxychloroquine per kilogram per day. So she has normal renal functions, and she had been monitored at our hospital for over 10 years. So initially, she had normal visual acuity. With time, she actually developed some vague loss of vision, blurring of vision in the left eye, with slight drop of vision from 7.5 to 610, and also a paracentral scotoma. And at this time, the spectral domain OCT, so in the left eye, there's clearly an area of thinning which was not previously present. Although I have to say, if we had looked at the OCT more carefully back in 2023, we should have spotted that it was abnormal at that time. So the line across the macula is actually the best way to show it. The structural damage, as you can see, the central is preserved, but the ellipsoid zone is completely destroyed outside the central macular region. So, and this was also confirmed with multifocal ERG, but to be honest, if the abnormality is so obvious on spectral domain OCT, you don't really need to do the multifocal ERG. So in fact, if you look carefully at the other eye, even the fellow eye is abnormal. So and this is the abnormal area, and this is what we need to pay. We need to pay special attention to the ellipsoid zone when we're monitoring patients for hydroxychloroquine toxicity. So the diagnosis is hydroxychloroquine maculopathy, left eye greater than the right, and of course the management is stopping the hydroxychloroquine. So once again, there's no proven treatment for hydroxychloroquine or chloroquine maculopathy, so prompt detection is crucial so that we can stop it before further irreversible visual loss develops. As you know, with hydroxychloroquine toxicity, the risk rises with the cumulative dose, so that's not only the dose per kilogram per day, but also the number of years that the patient has been on hydroxychloroquine. So the risk factors are for hydroxychloroquine greater than 5 milligrams per kilogram per day, the duration of use greater than 5 years, renal disease, concomitant use of tamoxifen, and also if the patient has macular disease, it may affect the screening and susceptibility to hydroxychloroquine and chloroquine. So basically, for this, there are standard guidelines, the AAO guidelines, and also the Royal College of Ophthalmologists guidelines. So these are already included in the handout, but I'll just go through them briefly. So this is the AIOS2025. So they recommend using automated visual field and spectral domain OCT. Also, we can use multifocal ERG or fundus autofluorescence, but time domain OCT, full field ERG, EMSLA, color vision, and EOG are not recommended. So when to screen? So fundus exam within the first year of use, and then additional screening after 5 years of use, unless you have major risk factors. So for the Royal College of Ophthalmology guidelines, I'll just take 1 minute to go through this. So I think it's easier to follow, actually. So if you have no risk factors, screening begins after 5 years. If you have risk factors like the ones I mentioned just now, you should start monitoring after 1 year of drug therapy. So you should, I think Royal College has decided to use spectral domain OCT and wide field FAF is because visual field can sometimes be it requires a lot of patient cooperation. So sometimes if the patients are not cooperative, you get some false positive and you don't know what to do about it. So if it's normal, you just continue monitoring them annually. If both of them are abnormal, then it's definite toxicity and you should stop the medication. If only one of them is abnormal, you proceed to Humphrey visual field, and then you can also do the multifocal ERG. And if the multifocal ERG is normal, then you continue annual monitoring. If it is abnormal, then you go on, you stop the hydroxychloroquine. And similarly, if the visual field is abnormal, and the spectral domain OCT and the FAF are abnormal, then you go on to stop the drug. So in summary, there's no effective treatment. So the main teaching point is that to stop it promptly. So for ethambutol, although there's no standard screening protocol, as a baseline, we need to do visual acuity and color vision at baseline and then self-monitor. And for hydroxychloroquine, we can either follow the AAO guidelines or the RCOP guidelines with fundix exam at baseline and then annual screening after 5 years. For RCO, you screen with spectral domain OCT and FAF, which are quick. And if there are doubts, move on to Humphrey visual field. And if you're still not sure, use multifocal ERG. So thank you all for your for attention.
Thank you, Dr. Chan. Any questions? The question is, why not use the GCC, ganglion cell complex thickness, as a baseline for ethambutol toxicity?
Yeah, I think that's a really quite good suggestion, because as we know, if we just do the RNFL, because we may not be able to detect it very promptly, because even at the onset of visual symptoms, the RNFL is likely to be normal, whereas the GC-IPL may be reduced. However, I think as a screening test, I think as a national screening test, I think we, of course, involve healthcare policies, and if everyone needs to have a baseline, because even the visual acuity and the color vision is currently done by our chest physicians. So if all of them need to come in for an OCT, I think we need to consider how we can implement that. But I think that's a great suggestion.
I think RNFL is for the masses, and it's faster protocol, easily done. And also I think initially the RNFL thickness will increase before the GCC. It's associated with some amount of edema. RNFL thickening, even in ethambutol toxicity. Not in every case, but probably subtle increase in RNFL thickness might set in before. GCC is all about vision loss. It takes a little time, unless it's an ischemic optic neuropathy.
But the optic nerves can look entirely normal as well, and the RNFL
yes,
may
it can have a very
be normal,
variable presentation.
so it can be quite variable.
I just have one quick question, Carmen. What is the timeline you decide that after stopping ethambutol, now this is time to stop INH?
This is actually a good question. I'd like to hear what you think as well. I think, for me, because any visual loss is irreversible, so I think maybe I'll wait for a month or so. If nothing has happened as yet, I'll ask them to stop the isoniazid. Well, consider alternative therapy to isoniazid, because after all, we have to take our chances. If we don't stop the isoniazid, if they do not have visual improvement afterwards, they may blame us for not stopping the isoniazid.
So maybe somewhere 4 to 6 weeks is what I think we plan in our country.
All right, okay. So it's great that, in fact...
And do you image all ethambutol suspected? Because you're going to have a bitemporal field loss. Do you image?
Well, anyone with a bitemporal field loss must image, because one man can have two diseases, and with bitemporal field loss, we can't afford to miss any pituitary or chiasmal pathology. Yeah, good point. Thank you.
Thank you. Excellent points. Any other questions? Any comments, Dr. Satya?
If I take progressive loss of
Yeah, logically, if the INH should be stopped if the vision.
I think definitely progressive loss, then the isoniazid should be stopped even sooner than 4 to 6 weeks. But if we stop the drug and if the visual loss is persistent and nothing has happened, I think 4 to 6 weeks is a great time to stop the isoniazid as well, even though it doesn't deteriorate any further. I think that's a great point.
Excellent points and an excellent talk. Thank you, Dr. Chan. So with that, we'll move to the next talk of the session, that is how to identify subtle and subacute optic nerve dysfunction. And to give this talk, I invite my very dear colleague, Dr. Vidya Dharni, consultant in Neuro-Ophthalmology Department, Shankar Nethralaya, Chennai. Over to you, Vidya.
Thank you, ma'am. So this will be about optic nerve function test and how to apply these tests in identifying subtle, subacute and optic nerve dysfunctions. The etiology of optic neuropathy cannot be made by the appearance of the optic disc alone. So these tests aid in identifying optic nerve pathologies or its absence. History and a good clinical examination is also an essential part of good clinical care. So these are the optic nerve function tests. Visual acuity is best tested with black on white background as it renders the highest contrast, but it does not reflect the visual field defects. Color vision, which is commonly tested with Ishihara's charts, in optic nerve disorders, the red and green is predominantly affected, while it is blue and yellow in macular disorders. Contrast sensitivity, which is a higher order test, it can be tested by Pally-Robinson chart. Pupillary evaluation, it's mainly identification of the presence or absence of RAPD. There are certain non-neuroophthalmic conditions where RAPD can still be present, such as dense amblyopia, retinal detachment, retinal vascular occlusions. Visual field testing in neuro-ophthalmology is restricted to central 24 or 30 degrees as there is an overwhelming representation of the central visual field in the human striate cortex. VEP, pattern reversal VEP is more sensitive, but it is less reliable when the patient has media opacities or poor fixation. In young children and patients are unable to fix, the visual assessment can be done with flash VEP. In presence of nystagmus and functional loss, pattern onset and offset VEP is helpful. ERG is helpful in those conditions or retinal disorders which masquerade as optic neuropathy, especially in pattern ERG. If the P50 component is abnormal and P95 is normal, it indicates a macular disorder rather than optic nerve dysfunction. So the other conditions where ERG is helpful for us is occult maculopathies, autoimmune retinopathies, and Azure. OCT, though it's more for a macular function, it does indirectly help us assess the optic nerve as it can quantify the axonal loss, it causes neuronal damage, and the pattern of the ganglion cell loss corresponds to the degree and pattern of visual field loss. So with this, I'll be moving on to a few case series. The first is a 22-year-old male who had an allergist to RTA 12 days back. He presented with defective vision in the right eye. Surprisingly, his visual acuity was normal, but he did have RAPD in the right eye. His color vision was normal too. His anterior segment and fundus examination was normal, so was his CT brain in orbit. So did this patient have a traumatic optic neuropathy? Yes, let's see his fields. He did have an altitude inferior defect indicating that he had a traumatic optic neuropathy right eye. The next is a 27-year-old male who came with a history of accidentally being aware of defective vision in the right eye 3 weeks back. His visual acuity right eye was 624, but pupillary evaluation was normal bilaterally, so was his color vision, anterior and posterior segment examination was normal too, and so was his fields. So what was the cause of subnormal vision in this patient? A simple test. The 4% base out test was positive, indicating microtropia. So when the optic nerve functions are normal, there is no optic neuropathy. The third case is of a 34-year-old female who the only complaint was shadowing of images since 20 days. Her visual acuity, pupillary evaluation was normal too. She had mild dyschromatopsia, and as we can see, the fundus was normal. On close evaluation of her fields, we can see that she has a central scotoma in the right and in the left eye and a supratemporal defect in the right eye, indicating a junction scotoma. That gives an indication that she had a SOL, which was proven by the MRI. She had a pituitary lesion. The fourth case, which even I was surprised and amazed, is a 29-year-old male who presented with loss of vision in the left eye following trauma a week ago. He had a history of assault with fist, ball pens, and multiple pins too. He was no PL in the left eye, thus he definitely had a RAPD. And you can see his external image. He had multiple needle prick scars. His fundus in the right eye was normal. In the left eye, though, he had mild blurring or superior disc edema in the left eye. He had inferior defect in the right, and corresponding to no PL, he had the waveform, the VEP was not there in the left eye. When we imaged him, he had a metallic foreign body in the right orbital region abutting the right globe. Thus, he underwent right orbital foreign body removal. When we reviewed him a month later, patient was happy and we were surprised. His visual acuity was 6.6. Definitely he did have RAPD. His color vision too has surprisingly improved. He did have a mild temporal pallor. Substantiating my surprise, he was able to perform a fields in the left eye which showed an inferior defect. And VP also showed a waveform which was absent earlier. So probably this patient had optic nerve sheath hematoma which subsided over time, leading to his improvement in vision. The next is a 34-year-old female who presented with painless and progressive diminution of vision in the right eye since 12 days. She also had a history of flickers of light and fading of colors. She was evaluated elsewhere and found to have a temporal scotoma, and VEP which was also done elsewhere showed delayed latency. She was diagnosed to have optic neuritis and advised IV steroids. When we saw her, her visual acuity was normal. Again, there was no RAPD. Color vision was normal. Anterior and posterior segment was normal too, and HVF showed an enlarging blind spot. So what did she have? We suspected her to have acute idiopathic blind spot enlargement syndrome, which was confirmed by an abnormal MFERG, which showed reduced foveal, para and perifoveal responses. This is my last case. Is a 21-year-old female, an engineering student, who had history of sudden drop in vision in the right eye 11 days ago associated with headache. Her color vision was normal. She did have RAPD in the right eye. Color vision was normal too, and anterior segment was normal. Fundus showed bilateral optic nerve, multiple drusen's, and though the subtle pallor in the right eye. To my surprise, she had visual field defects bilaterally. There were more nasal defects. Considering the patient's age and method of presentation, I suspected her to have optic neuritis. But her neuroimaging and workup for atypical optic neuritis was negative. So in this setting, a neuritis was unlikely. So what was the cause for defective vision in her? I went ahead, had a close look up at her EDI OCT, which showed multiple optic nerve head drusen's. There was a mild thickening of the RNFL in the right eye too. And look at her GCC. There is thinning in the temporal quadrants corresponding to the nasal visual defects bilaterally. So to end, so this patient had compressive optic neuropathy secondary to optic nerve head drusen's. Optic nerve functions aid in identification of presence or even absence of optic nerve dysfunction. History with clinical examination in most scenarios leads us to the most probable diagnosis. I will conclude with quoting Sherlock Holmes. It's always there, the truth. You just need to look for it. In our case, there is a diagnosis. We need to evaluate until we find out what the patient is having. Thank you.
Thank you, Dr. Vidya. That was a wonderful talk, and we'll reserve the questions at the end of the session. So we'll move on to the next speaker, our chairperson of the session, Dr. Shirka Basi. She's going to talk on clinical evaluation treatment of giant cell arteritis.
Temporal arteritis, it's basically a vasculitis of large and medium sized vessels. It can lead to severe complications if left untreated, including severe vision loss. The pathophysiology is characterized by chronic inflammation of the blood vessels. Histopathologically, it's characterized by giant multinucleated cells, leading to the name of the condition, and the cause of the inflammation remains unknown. It is believed to be because of a combination of genetic susceptibility and environmental triggers. The clinical features of this condition include a headache that is described as a new or an unusual headache in quality. Patient can also present with scalp tenderness, basically scalp sensitivity, or pain, particularly while combing hair. Patient also can complain of jaw claudication, pain in the jaw while chewing, and it's because of the inadequate blood flow to the muscles of mastication. Patient can complain of amaurosis fugax, that is transient visual obscurations prior to onset of severe vision loss, which is usually irreversible. Can also present with diplopia in case the cranial nerves are involved. Along with all these symptoms, the patient will have, you will have to ask for these symptoms, will have usually complaints of fever, fatigue, and weight loss, which are basically non-specific symptoms of inflammatory conditions. 40% of them have polymyalgia rheumatica. Now coming to arthritic ischemic optic neuropathy, which is the most dreaded complication of giant cell arthritis. It's characterized by sudden severe vision loss, and the fundus is characterized by presence of severe pallid disc edema. The underlying condition is occlusion or narrowing of short posterior ciliary arteries that supply the optic nerve head. And typically the patient will say that there is a graying out of vision, which can occur over days to or it can be even in a day. And the vision loss is irreversible, hence it's an urgent condition, we need to act immediately. So how does one diagnose? The diagnosis is basically, one needs to suspect depending on the patient's symptoms, and once suspected, immediately ask for ESR and CRP, which usually are elevated in giant cell in temporal arthritis. But the gold standard to confirm the diagnosis remains temporal artery biopsy, which has a specificity of 100%, though it has a sensitivity of 77%. So the temporal artery biopsy should be done as soon as possible, ideally within 2 weeks of starting steroids. So one should not withhold steroids for doing TAB. You can do the TAB even after starting steroids for around 2 weeks. The length that is required to be harvested has been variably reported from 5 millimeters to 3 centimeters. British Society of Rheumatology says we need at least 1 centimeter of the length of temporal artery because of the presence of skip lesions. The other ways one can diagnose this condition is you can use Doppler ultrasound, which has the sensitivity of 67% only, but has a good specificity of around 95%. What do you see? You see a halo sign, which suggests the inflammation of the arterial wall, and you can confirm the diagnosis of GCA. Other more expensive ways of confirming the diagnosis are CTA and MRA, along with PET CT scan, but these have lesser specificity than the ultrasound. Coming to the management of AION, we all know that it should be immediately treated with high dose steroids, and the typical dose is 1 to 2 milligrams per kg body weight if you're giving oral steroids. And in case there is already arthritic ischemic optic neuropathy with severe vision loss, one needs to give intravenous methylprednisolone 1 gram per day for 3 to 5 days. In case the patient cannot tolerate steroids or needs prolonged, has been on prolonged steroids and experiencing side effects, one can consider methotrexate, tocilizumab, and azathioprine. But if the patient is kept on steroids, one important point is these are elderly patients that are being kept on prolonged steroids. One must monitor these patients for side effects of steroids, which include osteoporosis, hyperglycemia, and hypertension. And prophylactic measures such as bisphosphonates for bone health should be proactively given. And frequent follow-ups with the rheumatologist are advisable. So what's the prognosis of AION GCA? One should be aware that this condition can have recurrences and relapse, and the long-term outlook can become very poor if there is a bilateral vision loss because of arthritic ischemic optic neuropathy. So let's look at this case. This 81-year-old lady presented to us with a history of very sudden decrease in vision in the right eye while reading newspaper. And she had a history of headache, loss of appetite, and jaw discomfort. She was treated elsewhere. She was diagnosed as central retinal artery occlusion and was treated with paracentesis, and she recovered a visual acuity of 3/60 in the right eye. She had a good vision in the left eye. Her visual field, you can see, is constricted on the right side. Left eye, it's good. So the patient was diagnosed as CRAO and was asked to follow up with the cardiologist. But she came to me for a second opinion, and looking at her symptoms of new onset headache, jaw claudication, I ordered for ESR and CRP. ESR was elevated, it was 75, but CRP was within normal limits. In view of the symptoms and elevated ESR and CRAO in an elderly, I sent her to a rheumatologist who asked for a temporal artery biopsy, which showed inflammation of intima, inflammation of vasa vasorum, fragmentation of internal limiting membranes with a few multinucleated giant cells. And there was also calcification of media, which was not a feature of GCA. There was calcification of media, which was a feature of Monkeyberg calcification of the media. Why we are looking for this diagnosis? Why I want to confirm? Because there is a question of saving the other eye, which will require steroids in case it's a GCA. So biopsy has kind of given the diagnosis that it's GCA, but with Monkeyberg calcification. So the case dilemmas here were that CRAO is an atypical presentation of GCA. Patient presented with that. Patient had a normal CRP, and even the histopathology got confused with the presence of calcification and Monkeyberg calcification. But we remained focused to the diagnosis. Patient did have GCA and was treated for the same. So in conclusion, arthritic ischemic optic neuropathy is a severe vision-threatening complication of GCA, and it can also present as CRAO and cranial nerve palsies, where the patient will present with diplopia. Prompt diagnosis and immediate treatment with corticosteroids are critical to prevent further vision loss in the other eye. However, once the vision is lost due to AION, generally it's irreversible. Hence, one needs to be very proactive in management. Thank you.
Thank you, Dr. Shikha. I think we'll move on to the next speaker. So we'll invite Dr. Rashmin Gandhi, who is one of the senior neuro-ophthalmologists in India. He's going to talk on monitoring optic neuritis and managing its recurrence, particularly the demyelinating neuritis.
Thank you so much. Thank you, Dr. Shikha, for stitching up such lovely case and talks together. And thank you so much for inviting me. So there are two aspects of the talk. One is how do you manage the recurrences and how do you follow up these patients? Now, recurrence is multiple sclerosis or demyelinating disorder is a neurological disorder where optic nerve is involved because of that systemic disease. So most of the recurrences will be managed by the neurologist. However, our role would be to guide neurologists and sometimes even indicate to neurologists whether recurrence is happening or not happening. So how do we do that? So there are several scenarios of optic neuritis that we would be dealing with. One is where we know that this is a confirmed case of multiple sclerosis. How do we confirm whether it's a case of multiple sclerosis? That's something which is outside the purview of this talk. And how do we follow up a patient who had a first attack and we still don't know whether the patient had, what was the etiology of the optic neuritis? So let's say first is a confirmed demyelination, which we picked up on MRI. Now, obviously, demyelination, the commonest etiology that we deal with in demyelination is multiple sclerosis. However, we have to remember that antibody-mediated optic neuritis can also produce demyelination, and they have a different kind of prognosis. They have a different clinical picture, and our role there is little more than a patient with multiple sclerosis. So let's talk about multiple sclerosis and how do we follow up these patients in our OPD. So what are we looking for? We are looking for recovery. We are looking for what happens to the optic nerve disease process and the clinical picture when you stop steroids, and how and if at all there is a progression of the disease. So how do we get to all these three? These are the tests typically that we would do in a patient who had had optic neuritis and who we are following up. So the first scenario in case of multiple sclerosis is what happened to vision. So what do we expect? A confirmed case of demyelination because of multiple sclerosis would follow a very typical route in more than 95% of the patients. Generally, when the patient receives steroids, once the course of steroids is over, patient would generally report improvement in vision. And more than, as I said, 95% of these patients by the end of 6 weeks would come back to baseline visual acuity. When we say baseline visual acuity, we are only talking about the Snellen's visual acuities. That's something which we are looking for. Now, if there was a deviation, let's say if patient said that with 1 or 2 doses of steroid, his vision or her vision went from 1 or 2 by 60 to 6 by 6, that's not very typical of demyelinating optic neuritis, and we might have to look for other etiology causing the inflammation of the optic nerve. What if at the end of 6 or 8 weeks vision did not improve? It can happen in a very small number of patients with multiple sclerosis. However, since that's not typical, we might also have to now start looking for other etiology. We are mainly looking for NMO and MOG. The other 3 tests, RAPD, color vision, and contrast sensitivity. All patients, as Vidya had mentioned, all patients with unilateral optic nerve problem would have RAPD, and that's the most objective test of optic nerve function. The RAPD may not directly parallel the visual acuity because RAPD is dependent on surviving neurons in the affected eye. So while the visual acuity might recover faster, you might still see RAPD for little longer even if the attack has subsided. Color vision dyschromatopsia actually lasts much longer. In fact, even after a few months, patients still can report washing out of colors, and you may find that patient may not have recovered full visual acuity, color vision acuity on HTRS chart. Same goes with contrast sensitivity. However, contrast sensitivity would improve faster than color vision. What about visual fields? According to me, visual fields is the most important parameter which we should be looking for. Because one, of course, we want to know whether the visual field defect has cleared up. However, the subtle second attacks can be picked up by visual fields even before patient reports the dramatic decrease in vision, in Snellen's vision. Mean deviation in Humphrey's visual field is one of the good indicator to say whether patient is going into attack. Any difference between the previous field in a mean deviation in a reliable visual field, which is more than -3 or 4, our antenna should be up. We may not start treating them, but maybe we can have those patients follow much faster. OCT, and I'll defer a lot of questions on OCT to our chief instructor, Dr. Shikha, who has done a lot of work on OCT. But OCT has an important role to play in multiple sclerosis when we are following up these patients. And let's look at it in VEP. According to me, VEP really does not have a major role now. VEP was a cornerstone of an investigative modality in multiple sclerosis before the MRI era, where we used to detect increased latency even in the absence of clinical disease in the other eye, and that used to be an indicator saying patient might go into multiple sclerosis. Now that role has been taken over by MRI. So as I said, pupil color vision and contrast sensitivity may not follow the visual acuity directly. What are we looking for in OCT? OCT generally would demonstrate thinning of retinal nerve fiber layer and GCC. Can the thinning tell us a little bit about what would have caused optic neuritis in an ambiguous scenarios? Well, it is said that if patient has multiple sclerosis, maybe you may have more thinning in the temporal quadrant versus an NMO-related optic neuritis where there would be a global thinning of retinal fiber layer. However, I don't think we can, at this moment, take this as a final answer. OCT, like VEP, can demonstrate subclinical thinning in the eye, which did not have a clinical disease, and that can tell you that maybe patient has a severe disease process. There have been papers which have tried to use OCT as a marker of a disease activity in the brain. It is believed that maybe secondary progressive multiple sclerosis versus a remitting multiple sclerosis, SPMS might have a little more severe thinning of the retinal fiber layer versus RRMS. And similarly, there have been papers which have said that OCT can be used as prognosticating factor for the future clinical disability. To my mind, I don't think it is still mature enough to use it in a clinical setting, but maybe something that we can look at more closely. And what is our role in instituting interferons? Well, that's something which obviously would be a neurologist's call, but we can contribute to defining a high-risk patient. So a patient a female with a MRI positivity and let's say retrobulbar neuritis, you know that she is a high risk, versus the same patient having hemorrhage on the optic disc. ONTT told us that if there was a hemorrhage on the optic disc, that probably gave a little more protection to that patient for the future development of MS. And maybe disease-modifying agent like interferons can be deferred a little bit in those patients. And that's our role. NMO, again, we follow the same protocol to follow up the patient. However, one has to remember that NMO is a much severe disease and vision improvement is not really as much as what we expect in multiple sclerosis. Rest all remains same. As I said, OCT, you'll expect much more thinning in patients with NMS. I'll take one more minute, Shikha. What about relapse and MRI? MRI in multiple sclerosis generally neurologists call, but they would do it every 6 months to 1 year, because you have to remember the basic difference between multiple sclerosis and NMO. Multiple sclerosis, once the disease process starts, the damage is done by continuous neurodegeneration. While in NMO, the damage is actually done by an attack. So between the attacks, if you can prevent attack, you can prevent further neurodisability. MOG is another antibody which causes an optic nerve damage. This has a little more favorable prognosis than NMO. And again, most of the time, MOG would be monophasic versus NMO, which can have recurrence. Now, I'll end with another case just to demonstrate as to what is our role. As I said, we do have a very significant role to play. A very senior physician in Hyderabad, his younger brother developed multiple optic neuritis, and the treating physician, and since a physician had his own neurology team, so they were not interacting with our neurology team. So they were really very worried. They suspected, the neurology team suspected that the patient has optic neuritis because of NMO, and they started on multiple treatment. Now, patient did well with the acute treatment, his vision improved. However, after 6 months, patient reported that he has a loss of vision in the same eye. And patient was started on steroids. The MRI was done locally. Patient was also put on rituximab, mycophenolate, and all of the treatment. However, when the patient was sent for follow-up after starting all this, we realized that there was no RAPD, there was no change in clinical ophthalmological parameter. And it turned out a little later the patient actually had a non-organic vision loss. So that's something which, while we can also guide them to say how severe the vision loss is or optic neuropathy is, our role also is to say that there should not be, because all these medications come with a significant side effects for a long-term treatment. So that's something which is our role. Thank you.
Great talk. Thank you. So we'll move on to the next talk. I invite Dr. Ambika to give a talk on fulminant IIH and papilledema associated with cerebral venous sinus thrombosis, a race against time. Our session is also right now a race against time. But we started a little late. We got the hall a little late.
Good afternoon, everyone. I think the whole topics are race against time, and mine is refractory IIH, cerebral venous sinus abnormalities. I have just tweaked the topic as sinus abnormalities rather than only thrombosis, because that's what we are going to talk on. We all are aware of the modified Dandy's criteria for IIH, but here what's important is before making a diagnosis of IIH, ensure all patients do get an MR venogram, brain and orbit. That's very, very mandatory before we make a diagnosis of a primary IIH, because you have to always rule out the secondary causes. These are wonderful diagrams in the textbooks which you can go and look as MRI findings of IIH. But most important is nowadays we have a wave of radiological IIH. You will get a lot of patients being referred to you as IIH. They may not have papilledema, but the MRI may show signs of IIH. Just don't fall for it. So this anatomical diagram shows that how the CSF circulates within the cerebral system, and it is all egressing through the dural sinuses, which eventually drains into the major jugular veins and goes into the system. But here are the key findings, like the transverse sinus, the superior sagittal sinus, and these are the ones, like what you see here is the problem which we have to watch out for. That's a stenotic transverse sinus bilateral. So what are the red flags of IIH which you have to be careful about? Because these are the conditions which can cause a patient lose vision within a very short period of time, and venous sinus abnormalities are one among them. So the cerebral venous sinus occlusion can be a acute or a chronic CVST, which is a thrombosis, or it can be a venous sinus stenosis. It could be of intrinsic or an extrinsic cause. So these theory you can just go and look upon, but ultimately they all cause a patient to go up in the ICP features present with a bilateral papilledema. So there are some risk factors which are associated with it. And what do you call as a fulminant IIH? Any patient who is behaving like a IIH, having a bilateral papilledema, raised ICP features, but with a severe headache and a pulsatile tinnitus and a galloping vision loss. You may see him just a week or 10 days back with a near normal vision, but they can lose the vision completely within 4 weeks with an advanced visual field defect with a massive papilledema and a severe accumulation of fluid in the OCT. This infographic summary is a very nice chart which is describing how you go about of an IIH, but the same can be, you can look into this complicated slide over here. This is the fulminant IIH, how you deal with. So if you are not able to make a treatment as fast as possible, at least try to get a temporary lumbar drain at least over a period of 24 hours, and then eventually you have to move on with a CSF diversion procedure or an optic nerve sheath fenestration if the vision is being threatened. So there are so many articles in the literature which are showing, and this particular one has shown that of the 72 patients who were with fulminant IIH, almost 85% of them required surgical intervention, and children had presented with 6-nerve palsy in the presenting nature, and most of this fulminant IIH, when they have a normal BMI, watch for anemia association. So if you have to think about the transverse sinus stenting, there are some literature which is showing that after the transverse sinus stenting, the anti-ICP treatment was discontinued in almost 10 patients, which is a good sign because most of these patients will require a chronic anti-edema measures, but stenting will help you step down on the pharmacotherapy. So this is one example of a case how we deal with. This is a 57-year-old male who was coming with a gradual drop in vision. Right eye he has lost long back, and left eye was also progressively dropping. He did not have a major ICP features, and he is post CSF diversion procedure. And he had a vision of hand movements, and that of the left eye was 624. You can see the right eye has already gone into a severe optic atrophy, and the left is still having a lot of disc edema. So, and the fields were washed out even in the better eye, and the CSF pressure consistently remained high. So we repeated the MRI and with an MRV, and that's what we figured out. He has a significant bilateral transverse sinus stenosis. So with that, we went ahead, since he has already lost one eye and the left eye is also dropping, we went ahead for a sheath fenestration of the right eye, and this is on day 1, and this is on 2 months follow-up. But after 2 months, we also advise the patient to go for a transverse sinus stenting because of a high transverse sinus pressure gradient. And this is the technique what we used in our setup. We just did a medial conjunctival approach, identify the recti, tag them, go to the medial rectus, engage, and then disinsert that from the globe insertion. Take a baseball suture for a firm hold of the globe away from the medial end to expose the optic nerve, and that's the optic nerve what you could see over here. That's with an MVR knife. I'm making a nick, and then with a Stevens scissor making a window, and you can see a clear egress of fluid after the second cut. So that's the sheath fenestration we follow. Just go back, suture the muscle and the peritomic closure. So after the sheath fenestration, he did get better by 2 months follow-up, but after the stenting was the complete resolution of the field loss what we saw in the fellow eye. But although the right eye remained not that great, and this is the RNFL and GCC changes, so you're dealing with an rapidly progressive visual decline, a patient walking into an ophthalmic institution. Maybe if you have great neurosurgeons in your setup, you can take their help, but remember we are ophthalmologists basically, so try to increase the help of your friends to perform a sheath fenestration. Yes, it has its own merits and demerits. It's very useful in rapid and progressive visual loss, but always it might require a secondary procedures, particularly when there are venous sinus abnormalities. So this is the comparison of a sheath fenestration versus a CSF shunt. And another factor is, do the optic nerve sheath fenestration prior to asking for a venous sinus stenting, because your neurologist and your neurosurgeons can put the patient on anticoagulants. So if they start that on, then it becomes difficult for you to perform a sheath fenestration. So always go on for that first. And there are so many literatures which are available which are comparing the sheath fenestration for even cerebral venous abnormalities, and they all have shown that there is a consistent improvement in the vision and the mean deviation in the visual field. Not only the visual acuity, there was also some amount of improvement in the headache in few of these patients. And what we prefer is a median transconjunctival approaches for the sheath fenestration. There are many techniques over there, and there are quite good advantages of going for this technique, and so do the disadvantages. But there are a lot of complications associated with a sheath fenestration, so you definitely need an expertise and a good plasty or any team which are going to really support you for this technique. And when there is a rapid visual decline, this is the fastest one which you can perform at your setup. So there are a lot of complications involved along with it. So to conclude, fulminant IIH is a medical emergency. It is vision threatening, and the patient can go to no perception of light within 3 to 4 weeks. So you have to be ASAP, go on for the maximum stiff anti-edema measures. If it doesn't work on, just move on to the surgical procedure as soon as possible. Sheath fenestration, CSF diversion procedure, or a stenting, whatever is available in your reach, go for it first. And bilateral edema, if the sheath fenestration is done in one eye, we can expect an improvement in the fellow eye. It is not that always we need a bilateral sheath fenestration. And most of the times these can stabilize the vision to a certain extent without going worsening. And secondary IIH is really complicated, and you might require a very good effective neurosurgery team for a venous sinus stenting. Thank you so much for the opportunity.
Thank you, Dr. Ambika, for this excellent talk. With that, we'll move on to the last talk of the session. And to give that talk, I invite Dr. Varsha Bhakyavati, who is an oculoplasty surgeon in Shankar Nethralaya. And she'll be talking about compressive optic neuropathy, orbital causes needing emergency decompression. Over to you, Varsha.
Hello. Yeah. Thank you so much, ma'am, for this wonderful opportunity. So I'll be talking on compressive optic neuropathy, orbital causes needing emergency decompression. So acute compressive optic neuropathy is considered as one of the treatable orbital emergencies, and it may be in the form of medical or surgical decompression. And if done at the right time with the right technique, one can salvage the vision. So the indications of surgical decompressions could be inflammation, a bleed in the orbit, air within the orbit, at times neoplasm, as well as foreign bodies. I'll be taking you through a set of cases. This is an 11-year-old who presented with left eye pain, swelling, and drop in vision for 4 days. And on examination, the visual acuity in the left eye was 618 with the relative afferent pupillary defect. And on clinical examination, as you can see, there was a lateral dystopia with a gross proptosis in the left eye. On imaging, a well-circumscribed, thick-walled, oval soft tissue lesion was seen in the medial orbit, displacing the globe laterally. And on contrast, a beautiful rim-enhancing lesion with central necrosis, non-enhancing in the center, was seen. This is, of course, was an orbital abscess, wherein the abscess is located in the orbital fat rather than in the subperiosteal space. So this child underwent an emergency drainage of the abscess with IV antibiotics, and he did very well and regained his vision to 6/6. So a few years back, we published this article wherein we noted that optic neuropathy was seen in 44% of cases among orbital abscesses. So here is another case, a 6-year-old child who presented with left eye painful swelling for 5 days, and on examination there was gross proptosis, lid edema, a tight orbit, and on imaging, as you can see, there was a collection in the subperiosteal space with maxillary and ethmoid sinusitis. He again underwent an emergency abscess drainage as well as a sinus surgery with IV antibiotics, and he did very well. So one needs to understand that we need to differentiate the subperiosteal abscesses and the orbital abscesses, which is basically done on imaging because the treatment varies. An orbital abscess requires immediate drainage, whereas a subperiosteal abscess, there are various indications, of which the compressive optic neuropathy is definitely one of them. Now, apart from bacterial infections, we can have fungal infections also present in an acute setting. This is an 11-month-old child who presented to me with painful swelling for the past 2 weeks. There was a gross proptosis with an orbital mass palpable in the inferior and medial orbit. And as you can see on imaging, there was an iso-intense lesion in the medial and inferior orbit extending up to the apex and compressing the optic nerve. So this child was immediately taken up for debulking, a canthotomy cantholysis was done, and a smear which was sent on the day of the surgery revealed aseptate fungal filaments, and which was confirmed by a pathologist. An emergent multiple debridements was done in this child with IV amphotericin and retrobulbar amphotericin, and this child at 1 month follow-up did quite well, though he had a residual optic neuropathy. Here is a similar case, a 25-year-old law student who presented to us with sudden drop in vision over hours in a setting of proptosis for 2 to 3 weeks. This again was a fungal infection under mucormycosis, but however we could not salvage the eye because it was so virulent that an excitation had to be performed. So we all know among the non-infectious inflammatory causes causing compressive optic neuropathy is none other than thyroid eye disease. Here is a 56-year-old who presented with drop in vision for 2 weeks in a setting of thyroid eye disease already. So his visual acuity was 618 in the right eye, 3/60 in the left eye with a gross relative afferent pupillary defect. And as you can see, there was gross proptosis, lid retraction and extraocular movement limitation. On imaging, there was enlarged extraocular muscles, hyperintense in T2, suggestive of active thyroid disease with compressive optic neuropathy noted in the imaging. So investigation also confirmed the same, and he underwent an IV MP for 1 gram for 3 days, following which the vision did not improve, and hence we went ahead and did a medial wall decompression and radiation also for 2 weeks. So his vision had improved to 6/9 from 3/60. So we have a lot of cases we have treated as a team at our institute, wherein we use the cocktail treatment, wherein we give IVMP, and if it doesn't recover, medial wall decompression plus radiation, which helps us in controlling the activity of the disease and prevents reactivation. Other non-infectious inflammatory lesions such as IOID and granulomatosis polyangiitis, however, do not need emergency surgical decompressions, and IVMP and oral steroids are a go-to treatment. This, I think, my neurophthal colleagues will be able to answer better. So retrobulbar hemorrhage, as we all know, is yet another cause of acute compressive optic neuropathy, the most common being a fracture with the retrobulbar hemorrhage, and of course are blocks and rarely squint surgeries. So one needs to understand, every one of us should be able to do a simple lateral canthotomy and cantholysis, which can be vision saving. A simple block at the lateral canthal area is being given here. We're keeping the forceps as a protection to the globe and doing a small canthotomy in the beginning, wherein the skin and orbicularis is cut to about 1 centimeter, and here we'll have to pull the lower lid laterally and then cut the lateral canthal tendon. So the superior crura also can be cut, and the orbital septum can also be opened. Beyond this, I think an oculoplasty surgeon to decompress the orbit can be called. So this is an interesting case wherein a 9-year-old presented to me following an assault 10 days back, and this particular child was actually advised an evisceration in the left eye because he had PL plus vision, a gross proptosis, and a complete exposure keratopathy with a pseudocornea. And on imaging, there was a large subperiosteal hematoma with a subdural bleed also. This child was immediately taken up for aspiration of the blood, and he underwent a therapeutic keratoplasty and a tarsorrhaphy. A simple aspiration of the blood can save the vision if it was done at the first day or immediately when the child was diagnosed. So this child post-operatively is yet to follow up with us in the next 2 to 3 weeks. So here is a 50-year-old gentleman who, as you can see, has a large orbital lesion eroding the frontal sinus. And he underwent an excisional biopsy. It was a cholesterol granuloma, doing very well for 1 week. However, at 2 weeks post-op, he came with sudden decrease in vision to counting fingers close to face. And as you can see, there was a gross proptosis and hair in the subconjunctival space. And on imaging, yes, it was a pneumo-orbit compressing the optic nerve, multiple ear pockets. So very simple emergency needle decompression of the ear was done. This is just to show how a very simple needle aspiration just decompresses. This is in the subconjunctival space. Obviously, we also drained it from the orbit. In a 2 months follow-up, he's doing very well. So orbital emphysema, also known as pneumo-orbit, is generally a self-limiting condition, just gets absorbed in 3 days. However, when there is optic neuropathy or corneal complications, then we need to intervene immediately. So we always think that neoplasms cause long-term chronic compressive optic neuropathy, but I'd like to just discuss 2 cases wherein needed immediate intervention. So this is a 9-year-old child who presented to me with left eye swelling for the past 5 months with sudden progression in 2 weeks with a drop in vision. So, sorry, I'll just take a few minutes. So as you can see, there was a large orbital mass which was compressing the optic nerve, and we did a debulking with canthotomy cantholysis, and histopathology confirmed it to a chloroma. And with just 4 days of chemo, as you can see, the tumor had nearly melted so very well. And at 1 month follow-up is doing very well, and he's been under follow-up for the last 2 to 3 years now. So this is a similar case where there is a pre-existing VLM, and he presented with sudden proptosis for 10 days, and there was a lot of exposure keratopathy and pseudocornea. And as you can see, imaging also revealed a VLM with the bleed. So in such a situation, again, we drained the bleed, and a scleral patch graft was done, and he actually eventually underwent a VR surgery and TPK and everything, and is on follow-up. So here is a coal miner who presented with a projectile foreign body 15 days back. The foreign body in itself is compressing the optic nerve, causing the drop in vision, and we went in and removed the foreign body, and he also had a vitreous hemorrhage for which he is under treatment. So here is another patient who's a 42-year-old patient who presented to us post a FES procedure done elsewhere, and he complained of intractable vision. And this patient had a medial wall fracture, and as you can see that there is no cushion of fat around the optic nerve because it had been inadvertently debrided during the FES. So I had done a fracture repair for this patient, and just after the surgery, while I was in the OT, we usually check the vision, and it was PL inconsistent, and there was a gross RAPDs, and I immediately went in and removed the implant on the same day within an hour. So luckily for me, the vision had improved to 6/9 from no PL, and there was a gross visual field defect as well, but yes, it was a good thing that he improved. So in conclusion, prompt clinical radiological diagnosis is vital, and timely surgical decompression can salvage the vision. Medical decompression does play an important role in select cases, and team effort always wins. I'd like to thank all my neurophthal colleagues, our cornea department, and radiologists, pathologists. It's always a team that helps us to do everything. Thank you so much for your patient listening.
Thank you, Dr. Varsha, for sharing such a beautiful series of very well managed cases. So any questions for any of the talks in the session? If not, then we'll conclude this session, and I call upon the speakers to please come on the stage for the photograph.